Good evening, everyone. My name is Karen DiMiola, and I am an assistant dean at UConn Law School. I am also a past president of the Connecticut Bar Association and a board member of the Connecticut Bar Foundation. Tonight, it is my pleasure to welcome you to this session, which is part of the Constance Baker Motley series on racial inequality, established by the CBA and the CBF. We look forward to continuing to explore topics related to racial inequality. Constance Baker Motley was a trailblazing civil rights attorney who became the nation's first African-American female to serve as a federal judge and later chief judge. Judge Motley was born in New Haven, Connecticut, and maintained strong connections to Connecticut throughout her life. Today's session is titled Structural Racism, a Systemic Illness. When Constance Baker Motley was a young lawyer and showed up at events, many children, she reported, and adults were surprised to see that a Black woman was an attorney and had such power and position. Judge Motley took that position very seriously, and she mentored and she guided attorneys throughout their career. Seeing yourself reflected in the profession, whether it's the legal profession or the medical profession, is extremely important to one's own identity and one's own experience. And tonight we're taking a step away, not too far away, from the legal profession and focusing on the health profession. Tonight, leading this session is Dr. Lazzarini from the University of Connecticut Health Center. Dr. Lazzarini has co-authored Human Rights and Public Health in the AIDS Pandemic, which was published by Oxford University Press. She has co-authored national surveys on health information, privacy, syringe-related laws, and HIV testing and counseling provisions, which have appeared in the Journal of the American Medical Association. She serves as a special consultant for the Georgetown Johns Hopkins Program on Law and Public Health and for the Centers for Disease Control and Prevention. She has worked with the World Health Organization on projects involving HIV-related legislation, employment policies, and human rights. Dr. Lazzarini, who is also an attorney, has been a tremendous resource for those of us who are not necessarily well-versed in the medical profession, and she has done a tremendous job in connecting health inequities to our Constance Baker Motley series. Now, before I turn over the mic, I will ask that you all view the chat function for this session's CLE codes and link to record the codes. We'll be sure that the codes are read aloud and posted in the chat during the presentation. And this time, I promise, I think that's going to actually happen. I know we had some issues last time, and I appreciate your patience. Additionally, at the close of the session, we do hope that you will provide feedback on the presentation using the survey link provided in the chat. Without further ado, Dr. Lazzarini.
Thank you. I'm very happy to be here, and I was very excited and honored that you all asked me to help set up this session. I know people will probably have questions. I hope you do. And what I'd like to suggest is that you use the question and answer function on Zoom. And if you put your questions in there, we will collect them and go through them to the degree we can at the end. My goal is to have our panelists each have a period of time to talk. We'll have an overview that's slightly longer, and then a series of panelists, all of whom come to this from different perspectives. All right. So first, as I said, I wanted to thank you. Usually I work in the healthcare setting, and so I'm actually excited to talk about structural racism and health disparities to what I'm assuming is more of an audience of lawyers and advocates and maybe even judges. I'd like to help with the speakers that have pulled together, help bridge the gap between clinicians and researchers and lawyers, judges, and advocates when we think about the impact of structural racism on health. Also, I wanted to observe that getting to do this session during February about Judge Baker Motley has been amazing because there's so much information that has been in the popular press about her during this month. And I would encourage all of you to look at, various podcasts and publications that you probably are somewhat aware of that have come out recently, both about her life and just updating her activities in the legal field. And then I also want to note that the reason we titled this session, as we did, Structural Racism, a Systemic Illness, was because it has both the sense of a metaphor and as a pathway between what we might think of as legal policies, legal and laws and policies, and health outcomes. So this isn't how structural racism causes systemic illnesses specifically. It is that we're trying to help people see that it is a systemic illness, in fact. So let's go on to our next slide. And how do we define a systemic illness? Next. The National Library of Medicine defines it this way. It means an illness that's affecting the entire body rather than a single organ or body part. For example, systemic disorders such as high blood pressure or systemic diseases such as flu affect the entire body. Next. In fact, treating a systemic illness can require systemic solutions or treatments. And you can see that this metaphor clearly applies to things outside of medicine. So let's go on. Next slide. And what are health disparities? Well, the American Medical Association and many other bodies define health disparities. And this is a current one that is in the AMA's Guide to Advancing Health Equity. And what they mean by health disparity are gaps in health status or health outcomes that are unjust, avoidable, unnecessary, and unfair. They're neither natural nor inevitable. Rather, they are produced and sustained by deep entrenched social systems that intentionally and unintentionally prevent people from reaching their full potential. And there's things in there that are extremely important. Health disparities don't just happen. We make them happen. Okay, next. And next. Thank you. So what do we mean by structural racism? Comrade Jones, one of the best sources to go to for definitions of all kinds of racism, has used this definition. When public policy, institutional practices, and other social and economic structures combine to perpetuate inequity between people of different ethnic groups, it's known as structural racism. Now, we can obviously expand that with much more detail in many more contexts, but I would encourage us to think about how the policy implications are that feed into the health outcomes that we're going to look at today. All right, next. So there's going to be a number of bullet points about this, but structural racism as a systemic illness in the body of the US shows up in a number of ways. It most obviously impacts Black and Brown Americans due to the web of historical and current policies that have systematically disadvantaged them while favoring members of what was the white Christian majority. Next. But racism limits social advancement and mobility in the same way arthritis does physically, and it is crippling our capacity to live up to principles of liberty and justice on which our country was founded. And again, next. As you can see, racism manifests itself in a manner similar to mental illness. We have long suffered under the delusion that systems of discrimination and oppression are compatible with justice and democracy. Next. And it even manifests itself as a cancer that over time has continued to corrupt the integrity of our social fabric and may eventually destroy our democracy. Next, because I want to attribute just go back one. Oh, yes. I wanted to attribute this because it came from a friend and colleague of mine, Dr. David Henderson, very recently when we were talking about this topic, and these things rolled off, these metaphors of the impact on people, the metaphorical impact and the physical impact were so great that I wanted to directly attribute them to his, what he had said. All right, next slide. Racism's harm is pervasive, but it's not limited to its impact on the most marginalized. Let's do the next bullet. As Heather McGee has argued, structural racism also harms all members of our society by weakening our sense of community and undermining efforts to create a social safety net of policies that can protect all vulnerable members. Next. The COVID-19 pandemic has highlighted the resulting failure of moral empathy that allows some members of society to argue that their right to ignore public health measures should exist regardless of the risk that it poses to others. All right. And with that sort of foundation, you can click through at least 3 more times. 1, 2, 3, 4 more times. These are going to be our speakers. I will introduce each of them as we start, before we start their slides. So I will start with Dr. Linda Berry, but we have a great panel of speakers today. Dr. Berry from the Health Center, Ms. Nichelle Mullins from the Charter Oak Health Center, Dr. Chang, also from UConn Health, Ms. Donaldson from the Connecticut Health Foundation, and Dr. Steele from UConn School of Medicine as well. So let's go on to the beginning of Dr. Berry's presentation. And let me just tell you a little bit about Dr. Linda Berry. She's a board certified liver and pancreas surgeon with a unique background in both clinical and basic science research. As an associate professor of surgery, Dr. Berry teaches at the University of Connecticut Medical School, as well as holding the position of Director of Multicultural and Community Affairs at UConn School of Medicine. In this capacity, she focuses on initiatives to promote diversity among students, residents, and faculty. She also facilitates community-based opportunities to address health disparities via mentored experiences and research. Dr. Berry has also been elected by the Association of American Medical Colleges to represent the interests related to diversity and inclusion for all the medical schools in the Northeast. She was recently elected to serve on the National Steering Committee for the AAMC, which is the same group, a group for women in medicine and science, focusing on issues of inclusion and equity. And so without more ado, I will turn the mic over to Dr. Berry.
Thank you, Dr. Lazzarini. First of all, I want to say thank you to the Connecticut Bar Association for this opportunity to present. And I also want to dedicate my talk to all the lawyers in my family and to the moniker of this talk, Judge Constance Baker Mosley. And in that vein, I've entitled my talk, Structural Racism in U.S. Healthcare, that you have to frame it as the fight for health equity is actually a fight for civil rights. Next slide. I wanted to start with a quote that many of us use, that Martin Luther King is attributed as saying, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. But that is not actually what he said. Please click again. What he actually said is, of all the forms of inequality, injustice in health is the most shocking and the most inhumane because it often results in physical death. And why I wanted to contrast the two is he did not say health care, he said health. And health is expansive enough to include where you live, where you work, how you interact with people, the opportunities that are available to you, and the fact that the endpoint, the impact, the cumulative effect is death. And so this was part and fundamental of his civil rights struggle as anything else. Next slide. So I like to level set. I think it's really important that we all start out from the same point in terms of how we define things. So let's talk about race and racism. We need to come to an understanding that race is not biologic. 23andMe has shown that I could sit next to a white person and have more in common with them than the black person on the other side of me. There's not a specific part of the DNA that says you're supposed to be a black person. There are a lot of other factors, that's a whole nother talk. But what it is it is a social construct. And it was defined by how slavery was established in this country. And so again, I go back to Kamara Jones and how we put the two together in defining racism as a system of structuring opportunity and assigning value based on the social interpretation of how one looks, which unfairly disadvantages some individuals and communities, while unfairly advantages other individuals and communities. And most importantly, it saps the strength of the whole society to the waste of human resources. Next slide. So this graphic is great because it kind of just shows how our own internal biases, it dictates how we interact with each other and how we think about how society should function. And that predicated on that, we developed our own policies and practices that became codified in law in most part, and so we look at the Voting Rights Act and how we had to redress these things. But because of the history of this country and the consistency of these laws impacting disproportionately certain groups of people, it's become embedded in our society in the context of structural racism. And what does that look like? And particularly in healthcare, you have inequitable outcomes and you have persistent racial disparities. It cannot be, and I submit to you the challenge that, and I'm going to use Black people as the example, that they are the most unfortunate group of people, that throughout history, they always are the one group that will always have the worst outcomes in every measurable venue: health, education, jobs. And so we need to really take a look about the insidiousness of structural racism. Next slide, please. So there are opportunities that we can work on to get to racial justice. So real quickly, there are different categories if you really want to look at it in detail. There's individual racism, which is internalized beliefs that one may have, and it can be conscious or unconscious. Then there's interpersonal. So you're taking your beliefs and it's going to dictate how you interface with someone else. And that can be expressed through biases or harmful actions. Next slide. But what really is the foundation for structural racism is when you think about how institutions make up our society. So there's institutional racism, which is organization-based, and it's not explicitly favorable to a dominant group, let's per se, but it does have a consistent tendency to disadvantage people of color. And it shows up in policies and practices and even how we treat each other. And that is based on prejudice and bias, and it's unfair. And so that means that certain goods, services, opportunities are not accessible to certain groups, particularly people of color. And so when you look at take the bigger picture of the system in which we all function, we get structural racism that has a broadly encompassing of how these institutions function and enable society to function. And it has a tendency to favor white people over people of color. And it's not an indictment of one group or another. It's just the way it was set up to be. And so it's been codified in laws and policies that have had a broad impact on local, state, and national levels. Next slide. And federal policy has in history shown to be has codified structural racism. I'd like to highlight a couple examples where I can show explicitly where structural racism translated into where we are today. And I will ask you, the audience of legal scholars, attorneys, and judges, to put yourself in these scenarios and think about what I can do to make a change. How can I make a difference? Next slide. So I'm going to give you a little history. The Hill-Burton Act in 1946 was also known as the Hospital Survey and Construction Act. It was signed, and in that context, it had developed hospitals in areas where there were none. And so specifically in rural areas, particularly where there were high populations of white people, there was a boom of building of hospitals and therefore increased access to care. In order to sustain that, it also had matched federal grant funding so that it wasn't just hospitals, you had clinics and rehab and nursing homes that were built. And so if a state or a local region agreed to the hospital being placed in, they were obligated to provide free care, subsidized care. That's where we cannot turn anyone away when they come to the hospital. So there's federal match dollars that the state put in order to sustain these hospitals, and that set the foundation for Medicaid. But one key thing, in order to get this passed, right, there were compromises to be made. Southern Democrats would only sign on to this law if they enabled the separate but equal care clause. And so that meant Black patients had to be treated at different hospitals. And that also meant that people who treated those patients, Black doctors, nurses, had to work at separate places. And that set the foundation for unequal outcomes in health for these patients. And it also empowered the state to determine who got the money and how it was dispersed. Next. And so it was not uncommon that you would see signs like this after it was signed. Next slide. I want to highlight the role of the American Medical Association. It is an institution that exists today, and many people go to them as like the spokesperson for how medicine should function in our current day. But back in the 1950s and even before then, up until the 1965, they were the most powerful entity that dictated how medical societies function. They had a very strong lobbying wing. And so they were one of the key spokespeople to endorse racial segregation in medicine. It wasn't just patients. It was how people were educated to become doctors, who became a doctor. They shaped medical education and the training of doctors and the access to care. They actually commissioned the Flexner Report, which was a landmark report looking at medical education. And based on that, there were 7 Black medical schools because Black pre-med students were not allowed to go to white medical schools. And so separate schools had to be developed in order to educate them. Once this report came out, almost all the schools were closed and only 2 were left, Howard and Meharry. So when you think about now where we say, well, we don't have enough people of color in med schools, there's actually a shortage of Black men in medicine, this has a legacy attached to it. They opposed Medicare and Medicaid. They framed it as being communism. And so it wasn't until 2018 that they actually apologized and acknowledged their role that they played in terms of racial segregation and poor health outcomes as a consequence of their stance. Next slide, please. So the National Medical Association was very instrumental in not just getting the passage of Medicare, they also were very instrumental of linking it to the Civil Rights Act. It is the largest and oldest medical organization representing Black physicians and Black health professionals, but it was also home to other groups that were marginalized and not allowed because they were not identified as white into medical societies and medical practices. Title 6 of the 1964 Civil Rights Act prohibits discrimination on the basis of race, color, and national origin in programs and activities receiving federal finance. So this was passed first. And behind the scenes, the National Medical Association, under leadership of Dr. Cobb, worked to say, listen, Medicare is our way to end racial segregation because hospitals that receive funds from Medicare are receiving federal funds and they cannot violate Title VI. So consequently, they marched, they lobbied, and they worked on the actual legislation and worked with Martin Luther King in this regard. And that's how we end up having Medicare, which was the first time that it allowed broader access for marginalized people, particularly Black patients, to get care. It also translated into increased numbers of Black doctors and trainees. Next slide. Yet, 58 years later, look at what is happening. We are now today declaring racism a public health crisis. So how far have we really come? Next slide. We were in the midst of a racial reckoning. And what happened was when we're in this post-George Floyd era, when George Floyd died, somehow it woke the consciousness of America. But look at the picture where you see 1963 and 2020. We're still marching for the same things. And while most America had a racial awakening, I would submit people of color have been undergoing an endurance test all this time. And what it means is that we as a society have a collective responsibility to make a change and acknowledge that there are structural components to the healthcare system and society that need to be dismantled. Next slide. I'm going to go really quickly through this because my colleagues will go into more detail, but I just want to make sure people understand what health disparities it means. It's a difference that is closely linked to social and economic and environmental disadvantage. There's social determinants of health that also affect how your health outcomes. But most importantly, it's important to understand that race and ethnicity is an independent factor. You could be very educated, have great insurance, but it's consistently Black patients have had poor outcomes. Next slide. So how is health equity defined? Now, I noticed like in a lot of political spaces, people use health equity instead of health disparities as if they're synonyms. They are not. Health disparities is where we are right now. Health equity is the destination. And the goal is to reduce and ultimately eliminate disparities in health, and it determines that adversely affects excluded or marginalized groups. So the ultimate goal is to realize when health disparities have been addressed. Next slide. If you just click real quickly through, there's several pop-ups. So you may have seen this graphic about health equity and health equality, but I wanted you to focus on the last one. We need to get to justice. We don't need to compensate for the barriers. We need to remove the barriers. And I feel like when we do that, that is when we truly remove structural racism in the context of healthcare delivery. Next slide. So I just want to contextualize all this in terms of where we live, Connecticut. It's the sixth wealthiest state, and it has metrics that mark as one of the healthiest. But disparities exist here as well among the same groups, mainly Black and Latino. Infant mortality has been shown to be inordinately high among Black mothers, who are 4 times more likely to die before the babies of Black mothers are 4 times more likely to die before age 1 when you compare it to the national average. There's the lowest life expectancies that are still predicted by zip code. And excess hospital costs are attributed to the same patients because they end up getting into the system late, have poor access, and poor health when they arrive. Next slide. So it's not exclusive to Black patients and Black residents of Connecticut. We've seen similar disparities in the Hispanic population in terms of insurance coverage and gaps in access to healthcare. Next slide. But it's also in the social determinants of health. So the same people who have poor health outcomes, have poor access to transportation, lack access to healthy food. They do not live in safe neighborhoods, and they do not have the best safe housing or affordable housing where they can have all of these other aspects of the social determinants of health improved. Next slide. And I just want to know, as long as I've been alive, and even before my time, nothing seems to have changed. Specific racial ethnic groups, rural and the poor disproportionately are affected, and it is predicated by poor access, poor quality, and increased percentage of uninsured or underinsured. And I wanted to say COVID has been like the hallmark of highlighting all of this, worsening underlying health disparities and exacerbated by the social determinants of health. So underlying all that, race is still a predominant factor because disproportionately Black and brown people are being affected. Next. So I'm just going to go through some real quick examples of what structural racism looks like today. And I start with COVID. COVID was a canary in a coal mine, and many of us were not surprised when certain groups were disproportionately affected. Next slide. COVID highlighted more than anything the impact of race as a social construct, because most of the people who were affected were frontline workers. They were redefined as essential workers, the grocers, the bus drivers, the gig workers, the Uber drivers. But it also highlighted the politics of empathy, or I should say the lack thereof. Many of the deaths that happened with COVID were behind closed doors, and so people didn't really appreciate the extent of it. Many people who were not people of color could go through the entire epidemic and not necessarily have many people in their family die from COVID. But it also highlighted that there were undersourced healthcare centers, lack of options to mitigate risk. They could not take time off. They did not have unpaid leave. They could not quarantine if they lived in congregated housing. And there was poor COVID messaging throughout this, so that when we did get vaccines and other treatments, the distrust was always there and could not be overcome in certain populations. And it also highlighted that, we need to make changes in how people live and work. Suddenly, we were able to get the homeless off the street and put them in hotels during the worst of COVID. But the most important thing was we did not have consistent data to this day about the racial and ethnic impact of COVID. And it tells us, without that information, we don't know where to put our resources and funding to make sure this doesn't happen again. Next slide. So this is a medical journal. I'm just going to take and explain talk to tell you. When we're teaching and we're learning medicine, we are taught these algorithms that are based on some, objective metrics in order to assess a patient and determine how to treat them and anticipate their outcomes. But it has been shown that it is predicated by bias. If the information that is measured is predicated on bias, the output, the impact will be biased. And so a lot of these algorithms, which were supposedly objective, disproportionately directed focus and resources to white patients compared to other racial and ethnic minorities. Next slide. And it's not just one field. It was in many different fields were impacted. I'm going to focus on renal disease, nephrology. Next slide. Many people, when they go to the doctor, they get a blood test and they say, oh, this is how your blood functions. We talk about your renal filtration rate, GFR. There's actually a subset that says African-American GFR. And the higher that measurement is, that means your kidney functions better. But it was predicated on a weird equation, which was the muscularity of certain groups of people. African-Americans were noted to have, in this study that was done, more muscle, therefore they had high protein, therefore they had high GFR. So they artificially inflated, it was a calculation that had a higher level for Black patients compared to white patients. What did that look like? That a white patient would be referred to a renal specialist before a Black patient. And what was missing was a connection that Black people have the highest rate of kidney failure, highest rate of being on dialysis, and the need for kidney translation. And the way I know that this is a social construct is that in the post-George Floyd era, it has been removed from hospitals. You will no longer see in many hospitals African-American GFR. And a patient once asked me, I am Chinese and African-American, which one should I be? Well, what kind of choice is that? I said, pick the best one, the one that makes sure you get to see a kidney specialist sooner. Next slide. I also want to show this, which was in the New York Times, which showed that one of the measurements for oxygen level in your blood, the pulse oximeter, was incorrectly reading the oxygen saturation in the blood among patients that had darker skin. Why is this important? Well, in the midst of COVID, this was one of the measurements which we used in order to determine if a patient was safe to go home or not. If it was not reading these numbers accurately, people probably were going home when they should have been kept in the hospital. And it wasn't known before because we did not have a consistent large subgroup like this before. And so when we look at it, we should think about how is technology being created that it would exclude a group of people or create numbers that are inaccurate and can determine whether if you are treated or not. Next slide. Lastly, I want to just highlight a disease that disproportionately affects Black and Hispanic people, lupus. It affects 3 times more common in African-American women compared to their white counterparts. Next slide. A new drug came out and it was called Benlysta. Next slide. And it was the first drug in a half a century to ever come out. The issue with this drug was it was not being prescribed to certain Black patients because it was documented not being efficacious in Black patients. Why? Well, this study was done in Czechoslovakia. So the FDA approved the drug that was done in a country that did not have a large Black population for a disease that disproportionately affects Black people. And they said, therefore, it was not efficacious. They had a small group of people in their sample. You can't honestly think that you are factoring in the people that need it the most when you conduct clinical trials and you market drugs this way. And it creates an unnecessary barrier for a drug that could help patients. Next slide. So just to put it together, you may have interpersonal, individual racism, but it's the structural that predominates in terms of the healthcare system. So if everyone became anti-racist tomorrow, it would not make a difference if we do not dismantle the structural components of racism in our healthcare system, because we consistently have poor health outcomes and health disparities. Next slide. So I'm not going to repeat everything except to say that structural racism is a foundation from which many of the negative impacts of health outcomes originates. And it's a structure that provides a context for negative interpersonal exchanges that is rooted in bias. And so if you can imagine, it's one of the reasons why the Black patient as an individual internalizes that negativity that they experience in the system that leads to lack of trust, avoidance, and low expectations. And so that just exacerbates the health disparities. Next slide. So what does racial justice look like in the context of our healthcare system today? Next slide. It requires, as I said, the dismantling of racism embedded in law and policies that fuel sustained racial segregation and perpetuation of health disparities among specific racial groups. Next slide. So what has happened is that many states have decided to declare racism a public health crisis. What does that mean? Well, when you say it's a crisis, that means that you have to identify the cause, the root causes, you need to study it, you need to get data. And then what happens next is the big issue. And so if you look at this map, there have been many different states that have declared it as a public health crisis, but the next steps have not been consistent. Some of them, it's only a statement, and that does not move the needle. What you need is to go beyond defining the problem, and it requires actionable data. We need to get data and know that we have to make changes based on that data. It's not enough to say numbers. We need to know, well, where are these numbers in terms of access? Where are these numbers in terms of deaths? Where are these numbers in terms of morbidity? And then we also need to look at our policies, not just proactively, but retroactively, and look at them through a racial and equity lens and make the modifications necessary. But it also needs to apply to budget and funding and resources and programs. But most importantly, you got to engage the community. The community engagement is fundamental to the success of these efforts, because the need to engage them with trust as a foundation is key. Next slide. So I guess I'm going to mention briefly that in 2021, Anti-Racism Public Health Act was introduced, and the goal was to establish a National Center for Anti-Racism at the CDC, and they also focus on law enforcement, violence prevention programs. And the key point that they wanted to underscore here is that we need to educate the public about the harms of structural racism. They wanted to make sure that we got data that was disaggregated by race so we can truly measure the impact of racism. And they wanted to develop not just a way to identify the social determinants of health and how it disproportionately hurts certain people, but develop interventions to actually address them and eradicate the problem. Next slide. Connecticut, and some of my colleagues may be on the line, but there were so many advocates who pushed to get this done in the state of Connecticut, and it was signed by the governor as declaring it a public health crisis. And in that context, we tracked racial and ethnic data. It also required implicit bias training, in particular among management of pregnant women, because we had really high numbers of maternal mortality, and I also mentioned infant mortality. Established a commission on racial equity in public health, and actually required reviewing the COVID response because there was some evidence of disparities. Next slide. So I just want to close that, to deconstruct structural racism, it requires certain components: a coalition of multiracial and multiple professional backgrounds, unwavering commitment, accountability, investment of resources, focus, fortitude, and most important, empathy. And I say that because I used to say every good doctor needs a lawyer, and I meant it in terms of litigation, but I think in order to get this fight to the end point that we need, which is health equity and racial justice, It requires a coalition of lawyers and doctors and social workers and other people who all work together. Because what's happening is a backlash. When you see there's only one constant, one universal, it is the only real truth: causality. Action causes reaction, and cause and effect. And so it takes a multi-racial and a multi-professional coalition to make justice happen. So thank you very much.
Thank you, Dr. Berry. I really, really appreciate it. And I think that there'll be some questions at the end if they aren't answered already. I think we're going to move on now to a different perspective, but related one from within the healthcare system. I want to introduce my colleague, my friend and colleague, Nichelle Mullins, who is also a lawyer, but she's also the president and chief executive officer of the Charter Oak Health Center, which was since 2015. Charter Oak is a federally qualified health center that was founded in 1978 and provides quality, comprehensive healthcare to the underserved population, regardless of their ability to pay. Ms. Mullins was born and raised in Hartford, Connecticut. She matriculated from Hartford Public School Systems and is a proud alumna of Thomas Snell Weaver High School. Ms. Mullins studied political science, African and African American studies at the University of Michigan, where she graduated with a Bachelor of Arts degree in 1997 and earned a Juris Doctor cum laude from Syracuse University in 2001 and a Master's in Healthcare Administration from Walden University in 2016. She's also an ordained minister and currently serves as an appointed member of the Governor's Vaccine Advisory Group and co-chair of the Allocation Subcommittee, which I'm very proud to have served with her on, and as well as the State of Connecticut Healthcare Cabinet and Behavioral Health Partnership Oversight Council. And she's the president of the Board of Directors of the Community Healthcare Association of Connecticut. She's also happily married to a judge, the Honorable Rahim Mullins, Associate Justice of the Supreme Court, and they have 3 kids. Nichelle, I will turn the mic over to you to do your slides.
Thank you, Zita. Good evening, everyone. And I am going to speak to you about structural racism in health from an FQHC perspective. We can go to the next slide. So just by way of background, community health centers were actually born out of the civil rights movement. So it's interesting that Dr. Berry, I hope I am saying your name correctly. Yes, Dr. Berry, you went through a series of legislation and you left off with Title VI of the Civil Rights Act of 1964. And then right after that, even after all of that work, health centers were still needed. So community health centers, the movement started in 1965, and this is the result of the work of community health and civil rights activists who fought to improve the lives of Americans living in deep poverty and in desperate need of care. It was based on a model that Dr. H. Jack Geiger, an American physician and civil rights activist, learned while he was studying in South Africa. And he brought this concept back to America. And this is where the community health center movement was started. Today, there are about 28 million patients who are receiving care from community health centers. Next slide. Federally Qualified Health Center. Federally Qualified Health Centers, or FQHCs, are community-based healthcare providers that receive funds from the Health Resources and Services Administration, or HRSA as we call it, to provide healthcare in underserved areas. These are areas that are designated by the government as underserved, meaning there are inadequate access to healthcare, medical, behavioral health, dental care. There are economic features tied to these areas in terms of low economic areas. And so they have a designation as an underserved area. Entities that would like to become an FQHC have to apply for federal designation through HRSA or the Bureau of Primary Health Care. There's a long application process. There's usually some legislative involvement in order to receive that designation. They operate as community health centers. Some operate as migrant health centers. Some have healthcare for homeless programs, and some have health centers that have residents of public housing or public housing programs. There are also some rural health centers. And as we will go through the slides, you will see that there are also health centers known as lookalikes. You can go to the next slide. Once you become an FQHC, there are certain program requirements that you have to meet. And I apologize, it looks like some of my slides are distorted, but there are, I think, 17 or 18 program requirements now. And one, you have to serve an underserved area or population. So you have to prove that the area in which you want to open your health center is located in an underserved area or population. You have to deliver high quality, culturally competent, comprehensive primary care. Your operating board, which is really, really important, has to be a board that is made up of patients, a majority of the board members have to be patients. And the intent is not just to bring in board members who are corporate professionals who have a service here or there. The intent is really to have board members who utilize the services of the health center, who understand the community, who understands what it means to be part of the community, and have an appreciation for the services that the health centers provide so that they can provide governance and guidance for the operation of the health center. The health centers have to be patient-centered and offer patient-centered care. The board has to be composed of board members who make up the patient demographic or reflect the patient demographic. We must meet minimum administrative, clinical, and financial requirements. And then once we receive this designation, we qualify for enhanced reimbursement from Medicaid and Medicare. That's often a touchy topic for providers who are non-FQHCs. But really, when you think about all of the services that FQHCs provide, as well as the requirements that we must meet, that enhanced reimbursement barely covers our costs. You can go to the next slide. 17 FQHCs in Connecticut. This is just a map that shows you our locations. 16 are full FQHCs, meaning we receive some sort of federal grant, and one is a lookalike. The lookalike means when you are designated as a lookalike, let me say that, you do not receive federal funding. You hope to one day receive federal funding. You are entitled to enhanced Medicaid and Medicare reimbursement, and you also have to abide by all of the program requirements. We serve over 390,000 patients in Connecticut. Therefore, we are a major provider of primary care in Connecticut. And this is important because as we go through these slides and we begin to talk about what happened during the height of the pandemic, I need you to remember that we serve almost 400,000 individuals. And this was as of probably 2019. That number grew during the height of the pandemic. You can go to the next slide. Center. So Charter Oak, this is a picture of our building. Charter Oak Health Center was started in 1978. And we started in a 2-bedroom apartment in a public housing project because the residents of that complex did not have access to primary care. The only way that they could receive healthcare services was by taking 2 buses. They took one bus downtown Hartford. They had to get a transfer and take another bus to Hartford Hospital in hope that they would be seen. Obviously, that was not the best way to receive care, and many people did not receive care. So they petitioned the local government as well as the federal government to start a clinic in a 2-bedroom apartment. Today, We operate this building, which is over 60,000 square feet. We serve over 19,000 patients annually, and we have 15 sites in Hartford and in Bloomfield. In 2009, Charter Oak received a $10 million grant from the Obama administration to renovate this building. This building used to be a building that housed state of Connecticut agencies. Once Charter Oak received this grant, the state of Connecticut conveyed this building to Charter Oak Health Center to use as a healthcare center. You can go to the next slide. And so while we talk about structural racism and systemic racism, here we are in 1978, after Title VI, where we're moving towards, dismantling racism, dismantling discrimination. Supposedly, you still have Black and brown people fighting for access to healthcare. These are some of the services that we provide now. And one of the things I want to point out is specialty care. That is not common for a federally qualified health center. It is not common to see nutrition or pain management or cardiology or podiatry being offered by an FQHC. Why do we offer it? Because specialists won't see our patients because they don't like the insurance they have. And we'll get into that some more. We can go to the next slide. Have been fighting structural and systemic racism from the very beginning. Racism is not always conscious, explicit, or readily visible. Systemic and structural racism are forms of racism that pervasively and deeply embedded. They are pervasively and deeply embedded in systems, laws, written or unwritten, policies, and entrenched practices and beliefs that produce, condone, and perpetuate widespread unfair treatment and oppression of people of color with adverse health consequences. This country was founded on racist and discriminatory rules, practices, and laws. Institutionalized racism in the United States has directly led to the poor health outcomes of people of color. And instead of addressing and fixing the issues, the system continues to exploit the same people who have been victimized for centuries, all in the name of the law. And so this slide represents some of the laws that have attempted to weakly address healthcare for poor people and people of color. However, due to a variety of reasons, whether opposition, weak language, or lack of enforcement, these laws never had the power or teeth to reverse the health effects of slavery and Jim Crow. So for instance, although Medicaid is available for people who live below the federal poverty guidelines, the system has been intentionally constructed to severely limit eligibility and force individuals who are insured through this program to only receive care from certain providers. These providers are often clinics and hospitals, many of which do not have high quality measures, they don't have access to specialized services, or they are located in facilities in desperate need of repair. And so I'll note that I do believe the original legislative intent behind some of these laws were positive. However, they were watered down through the legislative process to keep both sides of the aisle happy. People's lives were inevitably placed in the balance then, as we continue to see today. Of note, like I said earlier, Charter Oak did receive a grant from the Obama administration for $10 million to renovate our current main facility. But most of the health centers in Connecticut, I won't say all of them, but most of them are in need of a lot of repair. And the funding is just not there for us to repair our buildings. That inevitably impacts our ability to provide quality healthcare to our patients. And for a lot of our patients, for most of our patients, we are the only place they can go to. Our patients are majority people of color. They have language barriers. So English is not their first language. They live at 200% or below the federal poverty guidelines. And a lot of them are undocumented and scared. Go to the next slide. So, Dr. Berry alluded to the social determinants of health. And, what we saw during COVID-19 was that COVID-19 exacerbated the reality of the existence of social determinants of health. Our patient population was directly impacted by COVID-19, primarily because the underlying health and social inequities put people of color at increased risk of getting sick, more severe illness, and/or death. So if we look at neighborhood and physical environment, people of color were disproportionately affected by difficulties finding affordable and quality housing. Our patients have one of our top diagnoses is asthma. We find that a lot of our patients have asthma because they are living in environmental conditions that are unsafe, because that's the only place that they can live. And the landlord isn't being forced to fix those environmental issues. Those health issues exacerbated their illnesses during COVID. And they didn't have access to hospital care because they were being turned away from the hospitals. People of color disproportionately lack access to quality health care and health insurance and linguistically and culturally responsive health care. Providing linguistically and culturally responsive health care means more than just providing a translator. It's much more complicated than that, much more involved than that. Inequities in treatment may result in distrust of the government and healthcare systems. And these barriers increase risk for poor health and health outcomes. Occupational and job conditions, Dr. Berry spoke about this as well. People of color were overrepresented in essential work settings. And when I start talking about my work on the vaccine advisory group, it was very difficult to convince other people on the committee that it was necessary to prioritize these individuals for access to the vaccine. Even though they were needed, they had to work. We needed them to work because we needed groceries, right? We needed them to work because we needed to get to work, whether they were driving the bus or trains. We needed them to, or trucks. We needed them in factories because we needed our produce and we needed our meats. But we didn't want to prioritize them when it came time for the vaccine. Income and wealth, people of color generally have lower incomes, barriers to wealth accumulation, greater debt, and such challenges make managing expenses, paying medical bills, and accessing affordable quality housing, nutritious food, and reliable childcare difficult. And not to mention living in an area where there's a food desert, having access to quality food, being able to choose the types of food that you want. The things that we take for granted, it's not easy for our patients, for individuals who live in this community. In education, inequities in access to high quality education lead to lower literacy, lower school completion rates, and barriers to college entrance. There are inadequacies. And what we saw through the pandemic is remote learning exacerbated those inequities, whether it was poor bandwidth or internet access, no access to technology, or not understanding how to log on to school, to your classroom. All of those inequities played a huge deal, a great deal during the pandemic. And now we see that children are farther behind. Children of color, children in inner cities are farther behind in their educations than their white counterparts who live in the suburbs. The positive thing I'll say from COVID is that we saw people actually starting to accept the reality of the social determinants of health. For the first time, I think I heard people say they understood that social determinants of health existed, because prior to 2020 or March or February of 2020, we were still debating whether these things were real. But once COVID hit and people started seeing the data, which they could not disagree with, they started agreeing that social determinants of health are actually real. It was hard to deny given the exorbitant death rates among people of color. However, people are still unwilling to dismantle them. The racial justice protests during the summer of 2020 and the pandemic have placed a new spotlight on disparities in healthcare and health outcomes. Black, Hispanic, Latino, and Asian American people have had higher overall rates of infection, hospitalization, and death due to COVID than white people. The fact, it's not debatable. So the question is, what do we do next? We can't put our head in the sand and pretend like we didn't see all of this. All of this didn't happen. You can go to the next slide. I want to talk a little bit about, I call this slide the fight for access COVID-19. So, I did serve on the Governor Lamont statewide vaccine advisory group. I had the privilege of doing that and co-chairing the vaccine allocation subcommittee with Zeta. But prior to that, I'm the CEO of a health center. And when the pandemic first started and we started hearing about the nature of the virus and the protections that were needed, we quickly realized that we needed personal protective equipment, gowns, masks, gloves, hand sanitizer. And we had some in stock, but a lot of what our masks, our N95 masks, were expired. And we needed access to it. And so I started calling DPH, DSS. I was calling anybody who would listen to say, hey, we need to get some PPE or else we're going to have to close. And if we close, we have 20,000 patients who will not have access to services. And then the other health centers were having the same issue. And it wasn't until we had to get on the television, we had to get on the news, and we had to get on social media and issue an SOS in the sky, a cry for help, because no one was listening, because no one was paying attention to the patients that we serve. We serve poor patients. The majority of our patients are either on Medicaid or they're uninsured because they're uninsurable because they're undocumented. So nobody really cared about this community. And our patients were still showing up every day. Throughout the pandemic, from the moment it started until today, we've had hundreds of people walk through our doors. They never stopped. And so we had to fight for PPE. Then we had to fight for access to testing. Our patients would show up at hospitals and get turned away. We didn't even have the resources to test because the state didn't give us any testing supply. So we had to figure out how to test. So we reached out to Quest. We've partnered with Quest to figure out how we could test. The former DPH commissioner, God bless her heart, former Commissioner Renee Coleman Mitchell called me and said she had access to the mobile testing van. She brought it to our health center so our patients and some of our staff could get tested. It was the first time that had ever been done. And then we decided that we were going to hit the road to provide access to testing. Did we want to do it? That was not what we signed up for. When we became an FQHC, that was not a service that we technically signed up for, but it was something that we had to do because our community did not have access to testing otherwise. And Trinity stepped in to partner with us so we could provide greater access to testing. And so we took our vans and we went wherever we were requested, Bloomfield, Windsor, we even went to Colchester, Simsbury, and we provided testing 7 days a week. 7 days a week. And so then we, with the vaccine advisory group, as Zita and I tried to, and I will say Tiffany Donaldson was part of the vaccine advisory group as well, so I'm sure she will share her own stories. We had to sift through all of the data around, the vaccine and how much we thought we were going to be allotted, how much we thought the state was going to be allotted, and how we would make a recommendation to the Department of Public Health and ultimately to the governor about how to allocate or release vaccine to the public. And we knew what the data said. The data said Black and brown people were dying at alarming rates. Well, we were told Black people can't be pushed to the front of the line, but everyone was okay with pushing them to the morgue. And I'm being very blunt because that was how blunt the conversations were. We had to constantly remind and re-educate people on the difference between equity and equality. And then there was this, well, Black people don't want the vaccine because they're hesitant. That's not what I was seeing on the ground. That's not what the FQHCs were seeing on the ground. What we were seeing was Black and brown people couldn't get access to the vaccine because the state prioritized older white people over them. So every day when I drove up to my health center, the lines were long down the block, full of white people from the suburbs coming to get the vaccine. And I was told I couldn't give it to my own patients because they weren't eligible. Even though they were dying, they were at risk, they were essential workers. I was told they weren't eligible. Structural and systemic racism. This is that invisible, implicit racism that Dr. Berry was referring to earlier. So we had to figure out how we could make sure the vaccine was accessible to our patients and to the people in the community, the people who live across the street from us. And it was it was helpful that the mayor of Hartford declared the city of Hartford at risk. And that was the way that we were able to offer the vaccine to any resident of Hartford, regardless of age, whoever wanted it, they could come in and get the vaccine, but they had to fight the lines from the people who didn't live here, who didn't work here, and who would never come back here again. And so we've also been able to partner with the federal government to receive some vaccine and also to receive at-home testing kits so that we can distribute those to our patients and our staff. Next slide. Dismantling structural racism. Because systemic and structural racism permeates all sectors of society, addressing them will require action on multiple fronts. Acknowledging their existence is a crucial first step. We have done that, but now what? It's time for this administration, our legislative administrations, locally and nationally, to deliver on the promises upon which they campaigned and which they were elected. And since laws and policies have created racial inequities in our systems, legislative, political, and educational reform are integral to eliminating those inequities. And so how do we do that? And I just list a couple of ways here. We have to address and eradicate social determinants of health. We've talked about it for a long time. Now we need to talk about how we eradicate and dismantle those social determinants of health. Legislative reform and enforcement. The entire legislative process, in my opinion, must be reformed. There are significant holes and problems in the foundation of its structure that need to be addressed. Existing anti-discrimination laws need enforcement, and we also need laws with more teeth that adequately address problematic areas. Addressing power and money imbalances. You know, as much work as FQHCs do, every 3 years, we have to fight for more funding. So our funding will expire in a year or two. And then we have to go back to Congress and fight for more funding. I think we have proved since 1965 that we work, that we're necessary, and that we are so ingrained in the community that we need permanent funding. Yet we have to keep fighting for it. And I firmly believe that it's because we serve poor people. There's no reason why in 2022, we still have to fight for funding. And then lastly, radical truth-based advocacy. It's time that we speak the truth. Speak the truth to power, not be afraid of speaking up and telling our stories and and showing our patients how they can advocate for themselves. We, the people, want change, and we have to remember that that we have the voice, that we have the power, and that it's time for us to take back our power and to make change, demand change. We have seen a lot during this pandemic, and I know that I am tired of getting reports of friends and family who are testing positive and people in the community who are dying at all ages from COVID unnecessarily. And it's not necessarily COVID, it's the underlying health conditions that are associated with the social determinant of health that is causing it. And we can keep ignoring it, but that's something that our generation is going to have to live with. We'll have to live with that. We'll have to explain to our children why we didn't think it was important enough to end before they became adults. And so with that, I'd like to say thank you for listening, and I'd be honored to take any questions.
Thank you so much, Nichelle. We really appreciate it. We're going to try and hold the questions for the end, other than the ones that are popping up in the chat. So I would like to move us on to our next speaker, who is Dr. Rocio Chang Angulo, who is an assistant professor of psychiatry at our institution, University of Connecticut School of Medicine. And she specializes in working with multicultural youth and families, including a large Puerto Rico LC, I imagine it's corporation, where she adapted and translated educational materials about developmental trauma disorder for educators and clinicians. Currently, she's developing a Spanish curriculum on the intersection of domestic violence, mental health, and trauma with the Connecticut Coalition Against Domestic Violence and the National Alliance of Mental Illness. Dr. Chang has also worked with several grassroots organizations to ensure that the voices of families and youth are included in treatment, development, and dissemination. And we're very happy to have her speak on the impact of trauma on youth and how some of that translates into health disparities. I'll turn the microphone over to Dr. Rocio Chang Angulo.
Many thanks, Sira, and thank you so much for the invitation. It's great. It's a very honor to be here with all my colleagues. And I think that my take is going to be a little bit more in the microscopic sort of area. And just like Sira said, my focus is on trauma. And I just want to mention that the part of the slides that I'm presenting to you today are part of a curriculum that's called Think Trauma, has been developed by amazing colleagues from the National Child Stress Traumatic Network, where we have many wonderful resources for many different professions, including judges and lawyers. I hope that this information can be useful, and I'll be more than happy to share any of the resources that the NCTSN has. So if we go to the next slide, I'm just going to go very quickly with the objectives. So I'm going to describe the impact of traumatic events and adverse childhood experiences on youth expectations. I'm also going to go over a little bit about describing challenges of trauma-impacted youth face related to the social contract, biases, and systems they navigate. And I'm going to talk a little bit about how we can identify and practice components of a trauma-informed practice and use knowledge to support policy changes. If we go to the next slide, I would like to start with showing you a short video. And this is a video of the life of Khalid's brother. I'm pretty sure that many of you have heard about his story. He was an African-American youth from the Bronx, New York, who was arrested when he was 16 years old, and he was incarcerated in Rikers Island. And what I would like just to show a little bit of part of his story, because many of the work that I do is about telling stories and trying to understand how systems played a big component on the stories of many people's lives, in all our lives. and how also we experience and are impacted, our lives are impacted by trauma or adverse childhood experiences. So if we can show the video, I would really appreciate that.
We turn now to another tragic story about a young man who learned the hard way about the troubles plaguing America's criminal justice system. Khalif Browner was arrested at 16, never convicted of a crime, never had a trial, but spent more than 3 years in one of the most violent jails in the country. Tonight, here is Khalif in his own words.
You're supposed to be innocent to prove guilty, but the way the system is you're guilty till proven innocent.
Little did we know Khalif Browner was already dying inside the day we met him. At the easy age of 22, he'd already learned more about America's criminal justice system and endured more than any soul should ever have to. That's Khalif there on the floor inside Rikers Island, New York City's most notorious jail, beaten by a gang of fellow inmates, all caught on camera. At the age of 16, he was arrested and sent here for allegedly stealing a backpack.
It was like hell on earth. We were beaten, stomped by the correction officers, and they was just beating on me.
Beatings captured on surveillance video obtained by the New Yorker magazine, which first brought Khalif's story to light. In this video, we see him being escorted to the prison shower. He appears to speak to the guard, who in seconds is seen slamming him into a wall and then to the ground.
And I cried myself to sleep because it's like, I want to go home, and it's like they're not letting me go home.
To go home, Khalif's mother, Vanita Browder, needed to post bail of $3,000. Money, she said, she just didn't have.
What was your reaction when you heard that your 16-year-old boy was being sent to Rikers Island?
My heart dropped. You know, I had heard so many horror stories about Rikers, and all I could picture was him getting hurt in there.
Court records show Khalif had attempted suicide at least 6 times, spent 1,110 days behind bars, more than 800 of those in solitary confinement. His court date postponed more than 30 times. He endured all this having never been given a trial, never convicted of a crime. Finally, in June of 2013, all charges against Khalif were dismissed. But his experience exposed a troubled criminal justice system and the brutality of life behind bars.
I think at some point, almost a reckless disregard by the prosecutors in this case. They didn't care, Byron. They saw his file, they saw that he was in jail, and he'd probably take a plea, and they were hoping he'd take a plea.
The judge told me that if I plead guilty, I would release from jail that same day, but I didn't do it. You're not gonna make me say I did something just so I could go home.
When we first met him, November of last year, he was doing better.
So we can stop now.
GED, started classes, right now to another.
So this is only an illustration of a tragedy about what happened to a 16-year-old boy who ended up ending his life. He committed suicide after he was released from prison, from jail. So if we go to the next slide, I'm gonna try to weave in some of the experiences that Khalif had in my presentation. And I would like for you to think about what potential trauma reminders did you notice for Khalif? You know, he was out of jail and he clearly was struggling after 3 years of being there for a crime that he didn't commit. If we go to the next slide, please. Thank you. We understand when kids experience trauma, when they do experience adverse childhood experiences, when they go through adverse childhood experiences, which are before the age of 18, there are things that mark humans, right? So the previous life experiences create expectations that guide behavior. Many times expectations based on traumatic life events are shaped by the experiences of danger before and following traumatic events, just like we had watched of what Khalif was describing, messages from others and society, perceptions of best strategies to remain safe. If we go to the next slide, traumatic experiences shift expectations about threats to personal and community safety, and intergenerational trauma reflects the impact of trauma across generations. You see here a mother in distress. And if you have heard the story of Khalif, you notice or you will realize that this mother was terrified about the fact of what could happen to her child and was really trying to protect him as much as possible. And one day that mother agrees to leave her, go to a birthday party. That's the day that he was arrested. So intergenerational trauma with the prior experiences from mom and the sort of different experiences that she herself probably had gone through, and then the next generation of her children being also victimized. And here we need to focus a little bit about how the system plays a big role into youth of color's life and how we can sort of try to unfold that a little bit more with more understanding about different research studies that that bring us a big perspective about what happens to kids when they experience adverse childhood, when they go through adverse childhood experiences or trauma too. So if we go to the next slide, please. We are going to, in the case of Khalif, what we understand is that, you know, he went through breaking an experience of a broken social contract for him, right? And the question for us is how the systems make it easier or more difficult for him, for Khalif, to deal with his experiences. We can also think about the personal and family experiences of danger beyond trauma, further undermine belief in the social contract. And the next point is that, if you can just click on one more time. We can ask also how did institutions or providers make it easier or more difficult for Khalif to deal with trauma reminders. If we go to the next slide, I'm going to go a little bit over about adverse childhood experiences. This was a revolutionary, I would say, study that was developed in the late 1980s, early 1990s, where one psychiatrist and one epidemiologist joined forces to understand a little bit more about the role of adverse childhood experiences in adults. And what they did was they asked 10 questions to primarily white middle-class Caucasian people who were presenting chronic illnesses. And they asked questions related to, if we go to the next slide, please. Questions related to abuse, physical, emotional, or sexual abuse that these participants could endorse with a yes or no, whether or not they were physically abused when they were before the age of 18, whether or not they were emotionally abused before the age of 18, sexually abused before the age of 18. The questions were a yes or no. As I mentioned, the answers were yes or no, and there was no really measure of intensity or frequency, but they really needed to understand more whether or not adverse childhood experiences were part, or maybe they had some correlation with their chronic illnesses. They also asked questions about neglect, whether or not they experience physical or emotional neglect, and household dysfunction, whether a parent had a mental illness or a parent was incarcerated, whether or not the mother experienced domestic violence, if a parent had any substance abuse issue, or if the parents were divorced. So these 10 adverse childhood experiences showed us a lot. And if we go to the next slide, please. We also understand that there were a lot of adverse childhood experiences that were not asked, right? in the case of Khalif, we didn't ask whether or not the kid was incarcerated, whether or not he was subjected to violence in different other contexts, community violence, was mistreated, by systems. So all of these important questions that the original study did not have. The percentages of the adverse childhood experiences were really high, and the number of participants in the original study were more than 17,000. And they were really significant. And if you see the percentages, they tell us a very sad story about, the big sort of numbers and how adults remember what happened to them during their childhood. And if we go to the next slide, please, I need to go a little bit quicker. The remarkable thing about this was that adverse childhood experiences were connected with disrupted neurodevelopment. They realized that there was a serious impairment in social, emotional, and cognitive skills. People who endorse more than 4 ACEs, they also present adoption of health risk behaviors. They were more prone to disease, disability, and social problems. And as a result, they were dying 10 years younger than when they compare with the same peer population. So there are significant health outcomes for people who experience more than 4 ACEs in their lives. So if we go to the next slide. There have been latest studies that focus on urban populations, and unfortunately, what we already know is it has been proven again that if we go to the next slide, the percentages of ACEs are a lot higher than when compared with the original population. So this is actually, I want to bring this to all of our attention, because that means that there is more possibility for higher and more negative outcomes for the urban population. And if we go to the next slide, please. One of the pieces that is important is that we need to consider the adverse community environments and how they play an important role into the lifespan of an individual. And so these adverse community environments have to do with poverty, discrimination, community disruption, lack of opportunity, lack of economic, lack of mobility and social capital, poor housing quality and affordability, violence, and many other sort of adverse community environments that are affecting primarily people of color. And in the case of Khalif, this is something that was very noticeable. If we go to the next slide. So there is, it is important to realize that when systems are responsible for protecting children and the public do not understand the impact of trauma, they may intentionally cause further harm. And if we go to the next slide. It is recommended that we can focus on 4 R's. The Substance Abuse and Mental Health Service Administration states a program, organization, or system that is trauma-informed, realizes the widespread of impact of trauma and understands potential path for recovery, recognizes, as the other R, the signs and symptoms of trauma in clients, families, staff, and others involved with the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. And I'm gonna stop here, but I hope that I have raised an important issue about how adverse childhood experiences really played an important role in the development and the life of a person as a whole, even if follows into their adulthood, and it can become, it can really impact their overall well-being, not only of the individual, but the family and full communities. And I think that is our responsibility to try to bring more awareness and also bring some solutions. So thank you.
Thank you very much, Rocio. I really appreciate it. And I think that we could, anybody that wants to dig into this topic more, there's a lot of interesting empirical research about ACEs, and I think that it's one of those areas where you can see the impact of systems on people's health and on people's lives for years afterwards very strongly. For our next speaker, I would like to introduce Dr. Christopher Steele. Chris Steele is an assistant professor of medicine at the University of Connecticut School of Medicine in the Department of Internal Medicine. He was born and raised in Burlington, Connecticut. He graduated with an MD, MPH from the University of Connecticut. And I have to say, he makes me feel super old because I was one of his professors and now I work with him. But then he went on to complete his training at Johns Hopkins in internal medicine. He's come back to UConn and become a clinical and academic faculty member for us. And he's now the educational liaison for medical and graduate school education or graduate medical education. He teaches on numerous topics for the health and social determinants of health curriculum in the medical school. And his training has focused on bridging the gaps of the social determinants of health and high value care. And he oversees a pre-professional health program at UConn called UConn Health Leaders. And I'm going to turn it over to Chris at this point with the mic.
Thank you. Thank you, Zita. That was wonderful. I will try to go faster just because to make sure everyone doesn't have to hear me talk forever, but I kind of want to first put a plug in that this program I'm going to be talking about, UConn Health Leaders, is a partnership between a series of medical students and pre-professional health students focused on healthcare fields, mostly medical, some dental, some PAs and so forth. And this is their idea collectively of how to actually better address health inequities and systemic racism within our community as a forefront. Here are the learning objectives. I will discuss basically all three of them, where I'll provide some background, some gaps in the way we provide care as physicians or providers in general, and at least the way this program's addressed some of the disparities, and I'll go briefly into it. Those who are interested in the program more, feel free to contact me after I can discuss it more in detail. Since the Civil War, if you look on the chart on the left, healthcare has gotten better and better because we've kept people living longer and longer. There's only been 3 dips. 2 of them were the flu pandemic, as you see on the left, and the third one is actually the COVID pandemic. And it was highlighted already, so I won't go into too much detail, but the one thing about this pandemic, the 2020-2021 data says is there was about 1 year loss of life expectancy in the United States at that point. What the statistics tell you when you split it up even further, it was different between different races and ethnicities. Caucasians had about 2/3 of a year less of life expectancy as a cohort, Latinos 3 year, and Blacks 2 years less. And I think the problem with statistics is it doesn't tell you the whole picture. Still to this day, we try to understand this, and we've, being a part of this panel and discussion, you guys have heard some of the reasons why these gaps exist. But the thing that we need to start figuring out as a society and as clinicians and providers and community members is how do we start screening people and asking people about their social context and basically their social inequities and systemic racism, and how do we figure out what it is and then do our best as a community to address it. One of the examples of this that you guys have probably heard before, may have heard before, is the inequities of breast cancer in the African-American community. One of the studies basically shows that Black women, when diagnosed with breast cancer, have 40% more likely to die from it. And if they're over the age of 50, they're 2 times more likely compared to their Caucasian counterparts. And if you see in this chart here, 5-year survival for an African-American woman is 80% versus versus Caucasians, it's 91%, or 9 in 10 Caucasian women will live 5 years after their diagnosis of cancer. What has been found, or at least one reason, there's multiple, but a big portion of what might be finding is there's certain vulnerabilities different groups face. And in medicine, one of the limitations it's kind of been trained out of us is we don't spend enough time getting to know who we're taking care of and then addressing the other things besides the disease that sits in front of us. And one of those things is the social determinants of health, which you already heard the definition for, but a simpler way to do it is the economic and social conditions that influence either an individual or society's health. So the question is asked, and this is out of the University of Pittsburgh that looked at this. They said, what if we create a system, we use nurses and APRNs to start actually asking our patients, especially specifically focusing on the Black community, what are the barriers they have for their treatment specifically? And what you find when they do that, it's astounding, right? They actually created a program where they first did a survey and asked what were the issues were. And the majority of what happened was when patients were going under cancer treatment, it was the cost of care, getting to and from visits, managing side effects and not feeling they have the right, mistrust in the system to actually have the doctor listen to them. And when you actually spend the portion of time and make a conscious effort through especially they call it the ACURE study in this one through Pittsburgh, what you found was if you look on the graph on the far left, the before and after the Black population versus the Caucasian population on the right, is once you make an active effort to screen for these things, you actually get people to complete their treatment. So before they were doing this, it was about 80% of Black women would complete their treatment. And after, it closed the gap completely. And it was over 90% of Black women were actually completing their cancer treatment. And what the issue highlights in medicine is that sometimes we don't we focus so much on the disease and we're not focusing on the person. And if we spend time looking at the person we're talking to and getting to know who they are, we can actually kind of adjust the way we take care of them in a way that they actually get equitable healthcare compared to their counterparts. This image also came up. And what I want to highlight out of it from at least a healthcare point of view is the image on the left is the way many of us were trained is we use the same treatment, same therapy, same statistics for every single person. But as you know, not every single person has, the same, benefits or outcomes. Like, for example, this gentleman who's really tall doesn't really need a box to stand on in order to watch the baseball game versus this little child here needs probably at least 2 boxes. And if we use that standard approach, we're going to miss something and we're not going to take care of that population the same way. And the reality of it is what you highlighted before, and actually in multiple talks we've heard our speakers beforehand, is some of our patients are like in a 6-foot hole versus others, they have access and opportunities, so many things. So they just have so much to the system. And what we need to start doing is modifying our approach. Is the equity approach is based upon a patient's need, which is really important. And kind of highlighting this is there evidence behind the fact that our patients feel this way? And there's this great article, which I recommend all of you read, by Pauline Chen in September 11, 2008, called in the New York Times, called The Healing Doctor-Patient Divide. And one of the statistics she points out is in 1966, 3 in 4 patients had confidence in their doctor, but at the time this article was written, 2008, it was 1 in 3. And despite the fact that we made marked changes in therapy and treatment guidelines, a lot of the reason why is a lot of patients just felt like we didn't listen to them. From the patient point of view, when they bring up some of the stuff, the social inequities that may exist in their community, they actually expect us, one, that they should be able to talk to us about this stuff. And a lot of the other stuff too is, as if they bring it up, we should be able to help address it, which is actually not what a lot of physicians think. About 80% of them thought they lacked the capacity to actually both address these inequities and develop the appropriate relationship to do so. And a lot of the times it's cited in multiple articles, but it's based on the ability to have the right support staff, bandwidth. Visits for most physicians is anywhere from 15 to 20 minutes, if that. And just the excessive pressures and so forth, and just the training to be able to ask the right questions. And as a result, if you don't ask the right questions of what's going on with someone's health, how are you going to be able to address it, right? And we noticed this gap, and it was actually approached by 2 medical students that were in their first year, and they said appropriately, you know what, I noticed that some patients that we take care of don't get the care they need. And we have a solution, and they proposed, and I listened, and I thought it was a great one, and I helped them. This is really their idea. And they said, why don't we get people that are interested in careers in medicine, majority of them going to medical school, but there's a variety of different things, and give them the opportunity for direct patient care, which is something they need in order to get into medical school. they collect this information, but not only collect it, but address it by starting to find out the community partnerships locally to actually figure out what to make a difference. And, they'll put a little background on the pre-med students. The issues they usually have is they want to figure out if they want to be a doctor or not, but the opportunity for them to interact one-on-one with patients is very little. Most of the opportunities that they passive, meaning they're just a fly on the wall, or they're the one not actively having the conversation. For example, shadowing a doctor, writing down what the doctor says as a scribe, or actually translating, where they're actually supposed to directly say what the physician says without deviating from script. Versus the other options, you have to imagine there's barriers to accessing that too, like an emergency medical technician or EMT, the person that comes in an ambulance to your house to help stabilize you, or a nurse's aide. You need the schooling, you need the finances to be able to pull this off too, which is a problem. So the idea is that we get them thinking about this early. Can we actually get them more interested in this and be aware of it? But also, can we start helping collect this information to improve patient outcomes? And the solution is creating this program called Yukon Health Leaders. This is the team. This is me here. I don't know if you can see my thing. I'm the one on the left. The first two pictures that are after that are the two medical students who approached me. And it is composed of both medical students, and it's also composed of a variety of pre-medical students, majority here too, who have come together and said, as a team in the community through undergraduate, graduate, and I guess physician leadership, can we make a difference in our community? And the mission of Yukon Health Leaders, or UCHL, is to train the next generation of healthcare providers to bridge the gaps in healthcare for patients in Connecticut by addressing social determinants of health and other barriers that may exist. Because we realize, one, they have the time and the bandwidth to do so. And the second thing that was really important for my opinion too, is we're training them to realize how important this stuff is. So when it's their turn, this just is second nature. They know how to look this stuff up. They know how important it is. They know how to find community partnerships in their area that address certain social inequities, such as housing insecurity, transportation issues, and so forth. And they can do it fluidly compared to someone like myself who didn't get this exact training, had to learn on the fly, and or a lot of people that's actually either paralyzed and don't know how to do this. The way we did it, or at least a simplified method, there's a lot of more stuff which I will not share with you guys today, but is we partnered with our Department of Population Health here at UConn. And we created a survey that was populated off of an iPad that's locked. And basically what happens is the volunteer, who would be the one in the blue, would meet with a patient while they're waiting, would ask them if it's okay, and then they would actually screen for these social determinants of health. These are the ones that we ask about in essence too. And I personally, one of the things I was really strong about this is I really wanted to not only just ask these questions, but I wanted to make sure we at least had some community-based resource or way to address it. So the questions here we have, and then what would happen is we would go through the screening to census screening, work to work situation. If someone came positive for something, so for example, if they clicked say unemployed, it would pop up a questionnaire at the very end saying, do you want any resources? And they say employment resources. And the first thing would pop up, and there'd be a variety, usually 2 or 3 options in each one, where you say like the Goodwill of Hartford, and they had a little script they'd write. And if the patient was interested, they would connect them to the resource on spot. We always gave people printed resources too. We also trained the volunteers how to actually find this stuff on websites. There's actually websites dedicated to this, but ways, for example, if a patient says, no, this is too far for me, is there anything more at a local distance? We've trained them actually to use CT 211 websites and other resources too on the fly to actually find the resources, just call the resources there, the partnerships in the community again there. Because one of the issues we find as clinicians too is we actually don't even know who these community partnerships are. And one of the barriers to a lot of the patients that are suffering from multiple social determinants of health is they don't have access to easy transportation. So if it's not in walking distance, it can be really challenging. And this has evolved multiple times. We've been at a variety of different clinics. We actually had to go from a live environment completely virtual during COVID, and then we went back into a live environment. So we kind of reduced the amount of clinics recently just to make sure we had the live environment correct. But since September 2021, we are back live. We're at Asylum Hill, which is across the street from St. Francis. For our students that don't have access to transportation ourselves, we actually popped ourselves right at UConn stores in the family medicine department. And then we're both in the inpatient, so inside the hospital, and outpatient, or the clinics of Farmington at UConn as well too. And we did do a complete virtual experience where we called people during the pandemic and helped them address their social determinants of health too. Here's a sample. This is actually an older one, but a demographic criteria of what we found. And when we looked at everything, one of the things we highlighted is employment, adult education, and transportation were 1, 2, and 3 were the barriers that we found were the most. We were able to look by race and ethnicity to see how many people screened positive. The blue, in this case, the blue is how many people screened positive. The orange is how many people screened negative. In this case, what they did here is actually the blue and the orange as well. This is the total number of people screened, and then this is the number of positive. And there's no percentages here, but I can provide those for those interested. Round 1, this is where we beta tested it at the West Hartford Clinic, which we had kept closed just in the meantime while we were restarting back live. It was overwhelmingly positive. We only had 1 month because literally COVID happened the month after that, so we had to go shut down everything. And when we approached 500 people, of the 426 said, yes, I'll get screened. 186 of them, 40, of the people that went through the full screening, said they were at least positive for one thing. And 145 of them were interested in resources. And this is just amazing. And of that, 120 of them actually accepted the resources too. And we were able in there to, as you said, employment, transportation, and housing, to stratify what was actually important to that clinic. And same thing, virtual, we had very similar numbers, which for time purposes I will pass up on. But what we did was we actually called, and unfortunately, when you call people, a lot of people don't want to stay on the phone. But what we found was the ones that did, the 1,200 that did, 681 of them screened positive. So we were getting a lot of positives for people that actually did want to talk to us, and we did connect them to resources, which is amazing. The other cool thing about this is we are actually able to tell in the local area what was the more concerning thing. So in Farmington, for example, smoking cessation and employment were the 1 and 2, versus you go to Asylum Hill, which is that clinic right across the street from St. Francis. Adult education, so people that had a lower high school education were flagged. Transportation and utilities were 1, 2, and 3 that we provided the most resources for, which is pretty cool, because if we can work with a partnership, we can actually focus on what we provide if we're with a nonprofit to actually improve our resources. Because one of the things that could happen too is we can actually follow up and say, we connect you to adult education resources and see what % of the people said they were successful. And then theoretically, you could create, partnerships with nonprofits that want to improve the community and hit the highest targets in that area by knowing what people are reporting to, which is really fascinating. So for time limits, I will just give a brief future direction. So the direction that we're going to see is one of the areas that I've noticed is at least in primary care, general medicine, both pediatrics, family medicine, and internal medicine, we do a great job screening for this stuff, but we want to expand into the emergency rooms, which usually is the highest areas of barrier where people are really having issues with access to care. Surgeries and OB is another option too. Focus on specific health issues. So like inpatient, we're focusing on health literacy and helping to improve the way we deliver our knowledge transfer when people are leaving. And then other thing too is partner with local communities, as I mentioned before, so that way we can actually target what is needed in a focused manner, so that way we can provide better care. So I will turn it over back to Zita. Thank you guys so much.
Thank you so much, Chris. I really appreciate it. For our last speaker, I will move to directly. I want to welcome Ms. Tiffany Donaldson, who also has a MPH training, a master's in public health. And she is president and CEO of the Connecticut Health Foundation, overseeing the independent health philanthropy's work in grant making, policy advancement, strategic communications, and leadership development. She brings to the role a deep knowledge of healthcare systems and policy, extensive experience in grant making, and a commitment to equity. And I will turn the mic over to Ms. Donaldson.
Good evening, everyone, and thank you all for having me. I know that I am standing between some important things, which includes us ending on time, some of us grabbing dinner, as well as perhaps a little bit of Q&A. So I am going to move pretty rapidly, but what I will do is assure that I follow up with some slides as well as with some other resources, so that you can look deeper at some of the issues that I was going to cover, but I will move again very quickly. So I just want to highlight that we are a grant-making organization, the Connecticut Health Foundation, and we focus on systems change. What we really are working on are how do we change the policies, administrative policies, legislative policies that really impact the health and the lives of people of color here in the state of Connecticut. You have already heard from Dr. Berry and from Ms. Mullins as well, all of the disparities that are plaguing our state. But I just want to highlight that oftentimes people question the disparities in Connecticut because we are often deemed the fourth healthiest state. And again, even with that, we are often at the bottom 40 when it comes to national disparities in particular. More importantly, the life expectancy gap here in Connecticut is tremendous. And I will tell you that even just going from West Hartford to Hartford, which is less than 5 miles apart, one loses about 10 years. So there are extreme disparities that we are seeing across our state. And that's why so many of us on this call are passionate about ending it. I am not going to go through some of the statistics here because we have reviewed some of the disparities. What I did provide in my slide deck, which again I will share, are specific disparities related to Connecticut around asthma, diabetes, infant mortality, and maternal mortality as well. You saw this, Linda Berry shared this. This is from one of our publications on what causes some of these disparities. And you see, as we've talked about, some of the social determinants of health. I will actually say that I call them the structural determinants of health because we've created structures that have prevented individuals from having the appropriate access to the resources that they need to be healthy. But even with focusing on the social or structural determinants of health, it doesn't tell the full story. What we are seeing is that there are huge impacts to structural racism and the impacts that we are seeing on health. What we see are the discrimination reports that we see throughout our health system and individuals, how they feel and when they perceive the health system. But underlying that, again, are all of the structures that we have created, the laws, the environment that we've created that have produced the discrimination that we are seeing and have led to some of the disparities. We've already seen and talked about this in this talk around the different levels of racism, and it's not just interpersonal, it's institutional and structural, as we've already talked about. The question often comes up is, how do we delineate between socioeconomic status versus racism in our healthcare system? At the end of the day, it's not one or the other. First of all, racism has created, again, the socioeconomic issues that we see plaguing populations of health. But even when you control for income and education, disparities still are persistent. And one of the areas where we see this is in maternal health. We know nationally that a Black woman with a college education or higher is still 1.6 times more likely to die from pregnancy-related causes than a white woman without a high school diploma. And this is simply just one example. There are several other examples. There are tons of studies that have been shown that demonstrate how people of color just get desperate treatment when they enter the healthcare system. And it goes anywhere from when you enter with a broken bone. Before the opioid crisis, people are questioning why the opioid crisis hit middle America, particularly middle-class white individuals so much. I'm going to be very candid in saying that the studies showed that people of color, particularly children of color and individuals of color, were less likely to receive opioid treatment or pain treatment when they entered the healthcare system. This was desperate treatment, but we're seeing the impacts of that now. And even for heart issues in patients, we know that Black patients are less likely to receive therapeutic interventions. And I will highlight that these studies, which again, I will share my slides that point you directly to the studies, these are agnostic to insurance coverage, education, and socioeconomic status. All we know for sure, and what we know for sure, is that there is desperate treatment within our healthcare system. And also, there's a lot of research, in particular, David Williams out of Harvard does a lot of work that looks at the impacts of just the physical consequences of racism and what it means for people of color, how it impacts depression, anxiety, hypertension, and the links that micro and macro aggressions have on the propensity for individuals to have certain conditions. And so there's tons of research that just shows that racism itself has physical consequences for individuals. So what can we do about this? You've learned a lot and we've talked about a lot. And the question is always, what can we do? So I will highlight some of the things that we are doing at the foundation. And also I will end with talking about what all of us can do. So number one is making sure that people have the ability to enter the system. So assuring that people have coverage so that coverage is not an issue, that they at least can get their foot into the door to entering the healthcare system. We also need to collect race, ethnicity, and language data across our state, which we are doing. Because of Senate Bill 1, which is now Public Act 2135, our state is going to require the collection of race, ethnicity, and language data in our healthcare systems and also across our state agencies. Why is this important? We know that you do not improve what you don't measure. And we have some data, but oftentimes the data is lagging and the data does not tell the full story. So getting data directly from hospitals and from health systems, from health practices, and getting data directly from our state agencies will tell us the full story around how people of color are doing in our state and what are interventions that we need to implement. The other piece that we're really focused on are the expansion of community health workers. Now, again, everyone talked about the social determinants of health. Community health workers are individuals who are from the community and of the community, and they provide a direct link for community members, an individual guide, so to speak, through our complicated healthcare system. And there's study after study that proves the efficacy of community health workers in improving health outcomes for people of color. And lastly, using evidence-based practices in treatment. I will say that there are states like New York State that's really working on maternal health in particular, and they found that when they used evidence-based practices and guidelines for maternal health, they are now seeing a reduction in their disparities across their state because they standardized the care. So there's no confusion about how to treat a woman of color versus a white woman. There are standards of care that indicate that for individuals. So what can you do? Part of it is making sure that we are advocating for health equity in all policies. Health is just the output from all of the other issues that people are dealing with. We see health as just the downstream, the impact of the lack of social of structural determinants of health. We see it as the lack of having equitable treatment in our healthcare system. So really advocating for health in all policies is critically important. There are so many laws and policies that we have on a federal and state level that again prevent people from having access to the resources that they need. We need to begin to undo and rewrite those policies so that everyone has equitable access. And then community engagement all around is important, but specifically around civic engagement. And then again, lastly, it's education and awareness. We cannot improve issues that we don't know about. So making sure that we all understand the issues and can work collectively together to solve them. I went very quickly. Again, I will provide some resources in the end, but thank you.
Thank you so much, Tiffany. I really greatly appreciate it. I appreciate all of our panelists. I want to thank everybody. I also want to thank everybody who has stuck around to listen to us. And I'm going to turn this back over to the Bar Association because I think we're close to when we're supposed to stop. I don't know how you want to handle additional questions I want to say we had some questions at the beginning that I think were fairly well addressed in the slides defining structural racism. I think that there was a question about the federal poverty level that got clarified by looking at the transcript, but I do want to acknowledge that there may be other questions, so open the floor if people would like to either type it in. I think we may have to type in your question. We can address those, or any of the panelists who want to discuss any of these other issues that came up in the chat.
There are 2 questions in the Q&A. I'm not sure if you can
Let's
see.
see. I have seen those. I answered, one of them was, how do we define structural racism? I think that we actually have done a fairly, each person has given a definition of it, and I'm happy to turf that back to the panelists if anybody wants to describe it again. But I think the conjunction of policies and laws that have demonstrably significantly different outcomes among different racial and ethnic groups that we've described across healthcare, policing, and other areas. There's certainly evidence of that. If anybody else wants to pick that up, that would be great. If not, we can address another one. Any of my panelists want to step up?
Yeah, I think one of the issues was raised about race being a social construct rather than genetics, and then I brought up the issue in Czechoslovakia. I didn't go into the science. I would welcome you to come to a science class with us, but there's this concept called epigenetics, where your environment can actually impact your DNA and how you respond. And so, you know, the reason why certain groups of people get lupus is not necessarily related to their genetics. It could be to certain consistent types of exposure or inheritance of an immunologic condition, right? And so when you look at those things, that's where we're talking about equity. But I think the underlying question is, why would we expect a different medical response in Black people? I think what we're trying to say is that there are societal factors that impact your health and how you function, right? And so we're trying to mitigate those things through a variety of venues that we mentioned and interventions. And in doing so, we hope to reduce that difference. That's what we're trying to say.
And I'll also add that when we teach about race, the concept of race in health, one of the things that we actually start with is we don't even have a good ability to define what people have meant by race or who classifies people as one race or another. I think Dr. Berry used the illustration of a patient who is Chinese and Black, and where would they fit? What theoretical racial category would they be in for somebody deciding if either a particular drug is good for them or if they should be, you know, if a differential algorithm should be used for them. And unfortunately, in the past, most distinctions that were made in the healthcare system were not self-identified by the patients themselves, but were assigned by caregivers who could or could not be accurate about it. And we continue to want to collect data on race in health because of the evidence of health disparities. But it is not a simple question about, I mean, I've heard a lot of advocates recently, not from UConn, suggesting that we shouldn't collect any more data on race because somehow that action in and of itself is racist. But that way, if we were to do that, we would not actually be able to detect any of these health disparities, which is what I always say about lesbian and gay populations as well. If we don't count people by what they identify by, we won't be able to tell if they have health disparities, which may be the point at for some people, I think. We don't want to see those health disparities. Anybody else like to pitch in? Have any questions or comments they would like to add? Any of my other panelists?
So there's a question on the long-term health outcomes of social structures, of social determinants of health, and whether or not people are just expecting the government to provide resources to them. And at the end of the day, what we know is that the disinvestment in things like education, housing, and transportation is what is leading to a lot of the health outcomes that we are seeing in populations of color. No one's looking for a handout, especially when the government for so long did not give a hand to people of color. So because of issues like redlining, where communities that did not look like me were given more money for investment in education and transportation and resources, because of issues like redlining, there was a lot of disinvestment in communities of color. And that's what we are experiencing now. If you do the data, listen, I have lived in the suburbs of Connecticut, West Hartford, Farmington. If you do the data on even what is spent per child in the school system, you will see extreme differences between the two. Now, granted, I pay the taxes and I know the difference, but we have historically disinvested in communities of color. What we are experiencing now are just years of disinvestment. And so our goal is to figure out how do we reinvest in communities of color so that we can just even the playing field. Nobody's asking for more, they're just asking for what they never got.
And I'll just add, Zita, that, part of my presentation, pointed to the impact that the law has had on encouraging, creating separation, racism, discrimination, encouraging it. What I am demanding is that we use the law to dismantle it. So if that means, if that's interpreted as a handout, if that's interpreted as using the government to fix the wrongs that they created, that's exactly what I want you to do, because you created this problem, so fix it.
So I want to thank everybody again. And I think that now we really are well and truly over our time, and I don't want to impose on the Connecticut Bar Association a whole lot more, but this has been really interesting. I've really enjoyed spending time with all of my panelists, and I hope that other people have as well. Karen, Professor DiMiola, would you like to say your last words for however you do this usually?
I will. Thank you all so much for this amazing presentation tonight. I learned a lot. I appreciate your time and your remarks. I want to thank all of you in the audience for joining us today. This session, again, has been recorded. You have the codes in the chat. Health and equity, if you needed a reminder. Thanks to the speakers. Thanks to the Connecticut Bar Association and the Connecticut Bar Foundation staff and leadership for creating this session. Our next Motley Speaker Series will be on March 22nd and will be focused on critical race theory. Please be sure to follow the CBA and the Connecticut Bar Foundation communications for more information about that session. And also, once again, please see the chat for more information about this event, as well as this session's verification codes and surveys. Thank you so much. Hope to see you in March. Have a great night.
Thank you, everybody.